Hello dear friends, how are you doing today? I hope you are doing well. Now we are going to talk about uncommon blistering disease. Bullous, Pemphigoid, Dermatitis, Herpetiformis, Epidermolysis, Bullosa, Pemphigus, Vulgaris, and Porphyria, Cutanea, Tarda are rare blistering disorders that are important because of their significant mortality or morbidity. They should be considered when the more common causes of blistering disease have been ruled out and appropriate laboratory data have been collected. 3 of the 5 diseases, Pemphigus, Vulgaris, Bullous, Pemphigoid, and Dermatitis herpetiformis, are examples of immunologically mediated disorders. Porphyria cutanea tarda is a metabolic disorder characterized by defective heme synthesis and excessive porphyrin production. Epidermolysis bullosa is a group of genetic disorders with mutations that produce structural defects in the epidermis or dermis. Bullous Pemphigoid. Bullous Pemphigoid is an autoimmune disorder characterized by large, intense blisters that occur on normal or erythematous urticarial appearing skin. Subepidermal bulla are characteristic pathologic findings. The condition occurs in elderly patients 6th, 7th, and 8th decades. The preferred sites of involvement are the groin, axilla, and flexural areas. Approximately 1/3 of patients have oral involvement. The bulla do not extend laterally or negative Nikolsky sign like those of Pemphigus vulgaris. Healing usually occurs without scarring. Bullous Pemphigoid tends bulla on non-inflammatory skin and crusted residual bulla. Bullous Pemphigoid in dermis, we can see subepidermal bulla. Note, the bulla of Bullous Pemphigoid are tense occurring on the normal or inflamed skin. Direct and indirect immunofluorescence studies reveal a linear band of immunoglobulin G or IgG and complement C3 deposited along the basement membrane zone where blister formation occurs. The IgG autoantibodies are directed against 2 hemodesmosum-associated proteins, the Bullous Pemphigoid antigens BP230 and BP180 in the basement membrane zone. These antigens are found intracellularly in association with the hemidesmosum and extracellular in the lamina lucida, which is the uppermost portion of the basement membrane zone between the epidermis and dermis. Bullous Pemphigoid direct and indirect immunofluorescent staining shows a linear deposit of immunoglobulin G or complement at the dermal-epidermal junction. The prognosis is excellent and the disease usually subsides after months or years. The tendency for the blistered skin to heal results in a low mortality rate. However, the morbidity caused by widespread blistering requires treatment with systemic steroids, doxycycline, and immunosuppressive agents. Dermatitis herpetiformis. Dermatitis herpetiformis is a chronic, intensely pruritic vesicular disease characterized by grouped herpetiform papules, vesicles, and urticarial plaques, which are distributed symmetrically on the elbows, knees, buttocks, low back, and shoulders. The vesicles are often not intact secondary to scratching as a result of intense pruritus. The disease usually begins in early adulthood and the general health of the patient is otherwise excellent. Dermatitis herpetiformis, crusted vesicles on the elbow and knee, typical distribution. Note, because of scratching, excoriations rather than vesicles may be all that is seen in dermatitis herpetiformis. The typical histologic change of dermatitis herpetiformis is a subepidermal blister with neutrophilic abscesses in the dermal papilla. Direct immunofluorescence testing demonstrates granular deposits or IgA at the tips of the dermal papilla. Indirect immunofluorescence testing for IgA anti-endometrial antibodies is also sensitive and specific. Dermatitis herpetiformis, direct and indirect immunofluorescent staining shows granular deposits of immunoglobulin A in the tips of dermal papilla. Dermatitis herpetiformis, subepidermal bulla and neutrophils in dermal papilla can be seen. Dermatitis herpetiformis characteristically clears rapidly after treatment with dapsone or sulfapyridine, although the disease recurs promptly when therapy is stopped. Approximately 75% of patients have an associated but usually asymptomatic gluten-sensitive enteropathy. In these patients, a strict gluten-free diet causes remission or allows a significant reduction of the medication dose. Epidermolysis bullosa, simplex and recessive dystrophic types. Epidermolysis bullosa is a group of disorders characterized by mutations in genes that encode for the structural proteins of the epidermis and dermis. This results in epidermal junctional and subepidermal blisters produced by minor friction or trauma. These genodermatoses range in severity from being relatively minor to being severely disabling and fatal. Epidermolysis bullosa simplex has blistering limited to the hands and feet and is caused by dominant keratin 5 and 14 gene mutations. This defect produces keratinocyte fragility and intraepidermal cleavage. Recessive dystrophic epidermolysis bullosa results from mutations in the gene encoding type 7 collagen COL7A1. The severe form is characterized by midden-like deformity of the hands and feet, contractures, blistering, and scarring of the mouth and eyes, esophageal structures, growth retardation, anemia, and nutritional deficiency. Treatment of epidermolysis bullosa is symptomatic and supportive, including protection from trauma, good wound care, treatment of infections, and nutritional supplements. Epidermolysis bullosa simplex extends bulla in areas of friction on the feet. Recessive dystrophic epidermolysis bullosa, erosions and midden deformity of the hand. Note, epidermolysis bullosa can be mild to severe depending on which structural protein is defective. Pemphigus vulgaris. Pemphigus vulgaris is an autoimmune disease characterized by blistering of the skin and mucous membranes. It occurs predominantly in middle and old age with an estimated incidence of 1 per 100,000. The bulla are flaccid and superficial and range from 1 to 10 cm in size. They rupture easily, leaving large, denuded, bleeding, weeping, and crusted erosions. Pressure applied laterally to the bulla results in extensions and Nikolsky sign. The oral mucosa erosions of the mouth is almost always involved and is frequently the presenting sign. Pemphigus vulgaris, flaccid bulla and erosions. Note, the flaccid bulla of Pemphigus vulgaris prick easily, leaving erosions and crusts. The bulla of Pemphigus vulgaris occurs intraepidermally just above the basal layer. It is formed by the loss of cohesion between epidermal cells, acantholysis, direct with a patient's skin and indirect with a patient's serum. Immunofluorescence studies are positive, showing deposits of immunoglobulins, predominantly IgG or complement C3 between epidermal cells, intercellular space. Experimental evidence suggests that the interaction between the circulating IgG autoantibodies and epidermal cell surface antigens, adhesion molecule desmoglein 3 contained in intercellular adhering junctions or desmosomes leads to blister formation. In addition, the production of proteolytic enzymes that hydrolyze the cell surface proteins causes a loss of adhesion between keratinocytes. Before the introduction of systemic steroids, Pemphigus vulgaris was associated with an extremely high mortality rate. Systemic steroids, rituximab, and immunosuppressive agents such as methotrexate, cyclophosphamide, azathioprine, mycophenolate, mufacil, and gold are used. The overall mortality rate is 8% to 10%, and death now occurs more frequently as a result of steroid-induced complications than from the disease. Two other major types of pemphigus are Pemphigus foliaceus and paraneoplastic pemphigus. Pemphigus foliaceus often has an eczematous appearance with a few scattered small flaccid bulla and erosions and is caused by antibodies to desmoglein 1. Paraneoplastic pemphigus can clinically and histologically mimic a mixture of Pemphigus vulgaris and erythema multiforme. It is associated with a variety of tumors, most frequently non-Hodgkin lymphoma and chronic lymphocytic leukemia. Note, untreated Pemphigus vulgaris has a high mortality rate. Pemphigus vulgaris direct immunofluorescence revealing deposition of IgG throughout the epidermis, resulting in a chicken Y appearance. Pemphigus vulgaris direct and indirect immunofluorescent staining shows intercellular staining with immunoglobulin G and complement. Porphyria cutanea tarda. The porphyrias are a group of disorders characterized by abnormalities in the hem biosynthetic pathway resulting in abnormal porphyrin metabolism and excessive accumulation of various porphyrins. Porphyria cutanea tarda is the most common form of porphyria. It is characterized by subepidermal blisters on the hands and excessive uroporphyrin excretion in the urine. Polar vesicles, erosions, cross, melia, and mild scarring occur on sun-exposed skin, especially the dorsum of the hands. Facial hair predominantly on the temples and cheeks, and mottled facial pigmentation resembling melasma also occur. Porphyria cutanea tarda tends hemorrhagic bulla on the dorsal hand, the classic location. The bulla of Porphyria cutanea tarda occur subepidermally. Direct immunofluorescence reveals immunoglobulin and complement around the dermal blood vessels and at the dermal epidermal junction. The metabolic changes in Porphyria cutanea tarda are diagnostic, so immunofluorescence testing is not warranted. Characteristically, urinary levels of uroporphyrins and coproporphyrins are markedly rise with a ratio of uroporphyrin to coproporphyrin of at least 3:1. Liver function test results and serum iron levels are usually increased. The urine is dark brown and fluoresces orange-red under whose light. Varigate porphyria and hereditary coproporphyria have neurologic and abdominal symptoms as well as the same cutaneous findings as Porphyria cutanea tarda. The ratio of urinary uroporphyrin to coproporphyrins is 1:1. In varigate porphyria and feather serum or fecal porphyrin measurements are necessary to diagnose hereditary coproporphyria. Note, varigate porphyria, hereditary coproporphyria, and Porphyria cutanea tarda have identical skin findings. Porphyria cutanea tarda is familial or sporadic. It is often precipitated by alcohol, hepatitis C, or hormones like contraceptive pills. It is also strongly associated with hereditary hemochromatosis. The biosynthetic pathway for heme requires the conversion of uroporphyrinogen to coproporphyrinogen by the enzyme uroporphyrinogen decarboxylase. When this enzyme is absent, uroporphyrins accumulate and produce Porphyria cutanea tarda. The treatment of choice is phlebotomy or very low-dose antimalarials such as hydroxychloroquine given in single doses a few times per week. Case 1. Recurrent vesicles. This 32-year-old woman had a history of a recurrent vesicular eruption. It started 5 years before and it recurs 5 or 6 times yearly. A tingling sensation precedes the onset of the rash. What is your diagnosis? These grouped vesicular pustules on an erythematous base are typical of HSV infection. In addition, the history of recurrent vesicular eruption in the same place is classic for this viral infection. No other diagnosis should be seriously considered. What laboratory tests would you do? Exam preparation is all that is necessary to confirm the clinical diagnosis. If you are still in doubt, a viral culture can be obtained. What are your recommendations to this patient? Acyclovir, valacyclovir, or famciclovir may be used in patients with frequent recurrences. These medications reduce the duration of viral shedding and time to healing of lesions when administered early in the course of a recurrent episodes. Important points: exam preparation is an easy laboratory test that confirms the diagnosis of HSV infection. Acyclovir, valacyclovir, and famciclovir are the current treatments of choice for HSV infection, but they are not curative. Case 2. Crusted erosions on the dorsum of the hands and forearms. This 51-year-old man had a 10-year history of occasional blisters on his hands. In the last year, the blistering had become worse, with involvement of his arms, legs, and head. A trip to the beach flared the eruption. What is your differential diagnosis? Erosion suggests a blistering disease. The configuration, distribution, and history make an infectious cause such as herpes and impetigo unlikely. Acute contact dermatitis causes vesicles and bulla. However, there is no evidence of dermatitis surrounding the crust. Uncommon blistering disease such as Pemphigus, Bullous, Pemphigoid, Epidermolysis, Bullosa, and Porphyria should be considered. Hypertrichosis of his temples suggests the diagnosis of Porphyria cutanea. Tarda, what would you do now? A simple test is to fluoresce the patient's urine with a Wool's light. This is a quick screen for detecting elevated urine uroporphyrins. His laboratory tests revealed elevated liver enzymes, iron levels, and urine uroporphyrins. He had negative tests for hepatitis C, hemochromatosis, and HIV. His diagnosis is Porphyria cutanea. Tarda. Wool's light revealed a coral red fluorescence of the patient's urine compared with the normal lime green urine. How would you treat this patient? Treatment begins with preventing further liver and cutaneous damage by cessation of alcohol and precipitating medications, as well as starting sun protection. Phlebotomy is the first line of therapy. Low-dose antimalarials such as hydroxychloroquine can be used as an alternative treatment. Important points: when there is crusting, look for blisters. Consider a systemic disease in your differential diagnosis of skin symptoms. Okay, this was the end of our session for today. Thank you for your attention.